So my name is Alexandra Charrow, and I am a combined internal medicine and dermatology resident at the Harvard Combined Dermatology Program and the Brigham and Women's Hospital. Today I'm going to be discussing iPledge and its disproportionate effects on non-white individuals and low-income patients. And I have no disclosures. So as I think many people in this room are fully aware, isotretinoin is a highly effective oral medication used for recalcitrant and severe acne, and it has a number of side effects, the most notable of which is teratogenicity. And for that reason, a number of regulatory structures have been put in place since the 80s when the medication was put on the market in order to control for unwanted or unintended pregnancies during isotretinoin therapy. The most recent iteration of that system is the iPledge system, which was implemented in 2006 and whose goal was primarily to decrease the rates of pregnancies on this medication. For those who have not had the pleasure of prescribing isotretinoin under the iPledge program, it is actually quite a complex regulatory structure. So it involves really two main groups, those who are women of childbearing age and men and postmenopausal women or women who have had a hysterectomy. Every month, women have to come in if they are of childbearing age and are able to bear children, and within a 7-day window, they must obtain a negative pregnancy test. Their physician must document that they counseled the patient and also document a negative pregnancy test. The patient must then go on to the iPledge system and confirm that she is using 2 forms of contraception, and then finally the pharmacist must release the medication. So this process must be done within a 7-day window every month, otherwise the medication will not be released. This same process does apply to men and postmenopausal women, but the window is a little bit more liberal at every 30 days, but still those patients have to come in every 30 days as well. There's already data from 2011 that suggests that this iPledge system, despite its purpose being to prevent unintended pregnancies, has not been able to do that. So this study compared SMART, which was the previous regulatory structure, which was slightly less stringent, to iPledge, and noted no statistical significance in the number of unintended pregnancies. More importantly, all medications that are highly regulated, it has already been shown, are less likely to be prescribed to non-white individuals or low-income patients. So across the board, this paper is from 2003, prior to iPledge, and shows that there's a decrease in the number of people who are prescribed it based on race. There's white versus black patients. And if you look at other highly regulated medications such as Clozaril or other medications like that, the same data bears out, that the physicians are less likely to prescribe the medication even to begin with. So our intention was to look at whether the regulatory structure itself was overly burdensome once patients were on the medication, specifically overly burdensome to either patients of color or to low-income patients. So we looked at the RPDR database, which is a partners database of patients within the partners healthcare system. We identified non-white patients prescribed isotretinoin for acne. We age and sex matched them to white controls. And we looked at people who had been prescribed the medication in their first treatment course from 2008 to 2016. If you are a college student, as many patients in Boston are, and you received the medication partially at a partner's hospital and partially in California where you grew up, you were eliminated from the study. So it was only if you had your whole course within the partner system. And we then went through and extracted data from those patients. So we extracted patient demographics, including race. We extracted insurance type and at the treatment initiation, and that was important because we used insurance as a proxy for socioeconomic status. In the state of Massachusetts, insurance is required, and so 97% of patients within the state have insurance. And if you have a public insurance, you're more likely to be a low-income patient than if you have private insurance. And certainly if you have no insurance, you're very likely to be a low-income patient. We then went through notes from nursing and also physicians to extract information on both interruptions, delays, and early terminations of the medication, as well as the date of initiation and the total dose that each patient received. And you can see here we started out with about 1,100 patients, of whom about 250 were excluded because they had received some of their care outside of partners. 57 were excluded because it was not indicated, isotretinoin was not indicated for an acne treatment, and then others were prescribed it because this is their second or third course, so they might already be familiar with the iPledge system. And we ultimately had 663 patients who met full criteria for review. So just a little bit of demographic information on that population. About 300 patients were white, and the remaining 363 or so were non-white patients. About 72% had private insurance, and the remaining either had public or no insurance. And the age was skewed a little older at 29 in terms of patients who get isotretinoin therapy. So what you'll see here is pretty striking results. So when you compare non-white to white patients, you can see here non-white patients are marked in red and white patients are marked in blue. And the percentage of white patients who had delays, interruptions, or early terminations was significantly lower than those non-white patients who had delays, interruptions, or terminations. And the star indicates those differences that met statistical significance, specifically interruptions and early terminations met statistical significance. And then across insurance status, all three categories met statistical significance. Privately insured patients were much less likely to have a delay in starting treatment, an interruption in their course, or an early termination as compared to publicly insured or non-insured individuals. The reasons were also acknowledged when we went through the database, and we were able to find information on why many patients either had a termination, a delay, or an interruption in their course. The most common reason for a delay was a missed pickup window, a computer issue with iPledge, or a missed or delayed appointment. And that encompassed about 50% of the reasons for delay in starting the medication. The reasons for interruptions were also similarly missed or delayed appointments, missed pickup windows, or computer issues with iPledge. And then finally, the reasons for early termination are the very common reasons for early termination with any medication. In this case, it was loss to follow-up at over half of the patients. So I think this is quite striking results from our study. It really shows that there's a significant racial and socioeconomic disparity between patients with respect to isotretinoin initiation and course completion. And that especially makes a difference for a medication like isotretinoin, which is dose dependent. And the more medication you get, the more effective it will be for you. Non-white, publicly insured, and non-insured patients are just more likely to stop the medication prematurely and therefore receive a lower dose overall. And those reasons are intimately related to the regulatory structure itself. The stringent requirements of getting lab testing and then concurrent visits within a 7-day period has been overly burdensome according to the data that we found. And these findings are suggested to be overly burdensome specifically to individuals of color and the poor, at least in the Boston area. So I think when we look towards the future, we have to consider isotretinoin as compared to other Category X medications. Many people in this room prescribe other Category X medications, such as methotrexate, to young individuals. Many other physicians prescribe anti-epileptic medications, which are severely teratogenic as well, to very young patients in their teens and 20s. But they lack the isotretinoin's level of regulatory scrutiny and lack a system such as iPledge. And our data demonstrates that iPledge's regulatory scrutiny is really discriminatory towards the poor. I think that data, combined with data that suggests that it hasn't had much of an effect on unintended pregnancy rates, should make us reconsider the regulatory structure itself. Safety is critical to any medication that we prescribe, but in this case, the concept of over-safety or being too safe does have a cost, especially to our most vulnerable patient populations. With that, I would like to sincerely thank my mentor, the society, as well as all the wonderful researchers who worked on this project.
Thank you. Any questions?
That was excellent. One question I had is how early were they terminating? And what was the total dose they were getting compared to the ones that didn't terminate?
So that's hot off the press. We're in the midst of analyzing that data, and when we do ultimately publish it, we'll know for certain how much less medication they are getting, since that, I think, is really what matters. If somebody has an interruption or a delay, that's less important than if they get less medication overall, as I think you're alluding to in your question.
I have one observation. There's some earlier data, it might have been the study that you cited. I think it showed that the iPledge program did reduce the numbers of women who were pregnant at the time therapy began. But as you were pointing out, it didn't do anything to change the rate of pregnancy that occurs during the course of therapy. So wouldn't that speak to the fact that the initial time of starting the medication is the most at risk, and perhaps that could be regulated, but the other aspects have not shown to have an impact?
I think that's a fabulous idea, and certainly something for us to consider is whether we want to be stringent at the beginning when somebody's getting used to taking the medication, and then risk stratify our patients as we already do with other medications. So we will prescribe people 3 months of methotrexate without thinking very much about it, but once we've gotten to know them, we can know whether or not we think that they're more likely to be reliable in taking their birth control or other medications. I think that's a fabulous observation.
Okay, thank you.
Thank you very much.